welcome to our webinar, The Co-Benefits of Health and Health Systems for Democracy. When it's election time, we always wonder, will people cast their vote, and for what sort of party will they cast it, and what will be the result? What sort of government will we have, and what policies are they going to introduce with regards to health and health systems? Will they expand universal health coverage? Will they remove access barriers, or will they introduce austerity policies and expand, for example, co-payment? That's the conventional view, how we are looking at health, governments, and democracy. But today, for this webinar, we are going to adopt a radically different perspective. We are not asking what can governments and democracy do for health and health system. No, we are asking what can health and health systems do for democracy. So the question is here, how can we describe health as a driver of political participation and preferences, and what are actually the implications for policymakers and actors? This webinar is part of a loose series of webinars on the co-benefits. We are not asking what other sectors can do for health and health system. We are asking what health and health system can do for education, poverty reduction, equal opportunities. And today we are asking the democratic question. And to do this, we have a great panel of speakers. We have really the outstanding experts in this field. And I'm so happy to announce today that with us is Anil Menon, University of California, Merced, USA. And he's one of a pair of authors who have worked on this topic and published in scientific journals, and actually authored a policy brief, which you can easily download. We have his co-author, Nolan Kavanagh, with us from Harvard University and the University of Pennsylvania. We have also to introduce the patients and citizens perspective and the civil society perspective, Flavia Topan from the European Patients Forum here in Brussels. And last but not least, and you have seen him during the last couple of webinars, Scott Greer, University of Michigan, who has co-led our program on the SDGs and co-benefits. Before we go into the presentations, just a couple of things on the housekeeping. We are going to record this session. We will very soon upload it on our YouTube channel. And please use the chat box to insert your comments, questions, whatever springs to your mind. And we will feed this back to the speakers at the end of our session at the panel discussion so that your questions get a response. Okay, that's it from my side for the moment. Astrid, I think it's time to present the participants poll.
Thank you, Matthias, and also a warm welcome from my side to the panelists and the audience. So we're going to kick off this webinar with two questions. The first is a single choice question, and it is itself recognized as a key determinant for democratic participation in your country. And the second is a multiple choice question, that is, have any health policies been introduced to support democracy through lowering barriers to political participation for people in ill health, rebuilding trust by ensuring democratic institutions meet people's needs, using health system strengthening as a political platform, engaging with patient advocacy groups, none of the above, or all of the above. So yeah, get your results, poll results in, and I will be back to present the results later. Thank you. Over to you, Matthias.
Thank you so much, Astrid. And just to everybody in the audience, please take your time. I know that this perspective is slightly different from what we are usually doing. Think about it, and maybe you come up actually with a couple of very interesting results. So this is now the moment for me to invite Anil to present the results of a big study, of a very interesting study with a lot of methodology behind it. But also, Anil and Nolan, we are most grateful that you have converted this study into a policy brief, which makes it really accessible for policymakers and their advisors, because we believe it has very strong and important political implications. Anil, the floor is all yours.
Thank you, Matthias. And thank you, the Observatory, the London School of Hygiene and Tropical Medicine, Lucy, Astrid, all of you guys for organizing this. Quick nod of heads. Can everybody see the slides? Matthias, I can see you. Okay, great. So I'll try to keep myself strictly to time. And I couldn't ask for a better audience. So a big heads up. One of the data that I'll be sharing you at a very descriptive level today is coming out of the European Social Survey. And this is a survey that's been going on for more than 2 decades at this point, and it's done every 2 years, and it provides nationally representative probability samples for European countries. And it's an amazing resource for researchers. And if you're interested, it's available to the public. Dive in, you can find some really interesting things about the countries that you care about. My partner in crime, Nolan Kavanagh, he'll be fielding questions later on. And we're really excited to hear what Flavia has to say and what Scott has to say about the work and about their own work. So in many ways, you know, health has been moved into the limelight. It's become a very salient issue in European politics and global politics. And before we get into all of that, what motivated us to dive into this was this statistic, this fact that there is widespread mistrust across European countries. So you see this map here, but to kind of translate that, if you look at mistrust in politicians, over 75% of the countries on that map have a majority of people saying that they don't trust politicians. Maybe not surprising. About 1/3 of people say that they don't trust democracy. So 1/3 of these countries have a majority of people saying that they don't trust democracy. And that number is at about 40% for health systems. So in 40% of European countries where the ESS has been conducted, 50+% of the population say that they don't trust their health system. What's going on here? And it's, you know, it's across the continent. And we kind of wanted to see, because I'm a political scientist, Nolan is a political scientist and a public health researcher, we wanted to see how health might be feeding into some of this. And where we went to first is it's called the Michigan model, or the funnel of causality model, to try and understand how people vote. How do we make the decision to vote for a particular party? And for the longest time, this research has focused on the social influences and the economic influences. So where did you grow up? What kind of community did you interact with? What's your income? What is your education? These were the things that were particularly top of mind for researchers. And we started asking, we're like, well, there is another thing here, which is the fact that your health is fundamentally important for your ability to interact in society, your ability to participate in politics, the ability for you to be a productive economic citizen. And these things are interlinked, but the research across several disciplines had not taken that seriously. And so health influences are, you know, it empowers us to be a member of society. It empowers us to work. It also makes a difference for how able we are to participate in family life. So we posited that it affects political behaviors, and then there's the cyclical feedback loop where your behavior in the political realm can influence who gets elected into office, which has implications for the policies, repeat cycle. And so what does that look like? So translating that figure from before, if you look to the right-hand side of this panel, what we find is that when people are asked, how do you feel? How would you report your health? Individuals who rank lower on the spectrum also share a greater mistrust of politicians, of parliament, democracy, and the health system. So this is unadjusted raw percentage numbers. In our own work, we account for a variety of factors. Most prominently, possibly for this audience, you'll be wondering, isn't this income? Is this maybe the country of origin, like occupation? We account for, and the work that the work across economics, political science that we public health that we encountered, they account for a variety of these factors. And we'll, in the Q&A, we're happy to get into more details as to the robustness of these findings. But across the board, worse health is linked with lower trust in democracy, politics, and health systems. And another way of thinking about this is worse health is also linked, it seems, in every single country that we could study across the European continent with a lower satisfaction with democracy. It's a quite robust pattern at every country level. And the studies, if we go back 20, 30 years, they tended to find that people in poor health voted for maybe left-leaning parties. But there's been a shift, particularly pronounced after this 08 financial crisis, where people are feeling left behind. They feel that the system is biased and broken. When you have a decline in health, you feel like the institutions are not there for you. You feel left out. And that is moving them towards fringe parties, particularly on the populist right. And some of our own work, we find this relationship across all of Europe when we used data in the last 20 years. And the interesting thing is that there's been work that finds this relationship also at the community level. Work in the UK focuses on deaths of despair, finding that places that saw greater mortality rate from a variety of causes possibly were more likely to vote for Brexit. This result is also replicated in the context of the United States. There is quite a lot of work that suggests that there is a linkage between a decline in health and political preferences. And so that's something that, we should care about. Why should we care about this? Well, COVID-19 erased years off of the life expectancy advantages we'd gained over the last few decades. Between 2020 and 2021, we saw 1 million excess deaths across the continent. Mental health deteriorated, particularly among young people. And there was a lot of disruptions to healthcare provision, service quality. And so health became this very salient issue. And, when 1/3 of the population of Europe expresses that they have longstanding illness or health problems, it's a large constituency. We might want to care about how they think about various issues, how much they trust the system, because one of the findings, and one of the very stark findings in this space, is that people in poorer health are about 10 to 20 percentage points less likely to take part in the electoral process. So that is a massive gap. And the consequence of that is that the elected officials are less representing of these individuals in poorer health. They feel social stigma. There's work that shows that health practitioners admit to having biases against people with certain health conditions. They feel less welcome, less able to interact in certain environments. And it's not the key thing here, right? Is it's not that a decline in health automatically creates a reduction in trust. What it allows for is you have a decline in health that requires you to seek help. And that increases the number of opportunities that you interact with public institutions, which increases the number of times health practitioners, public institutions can fail, which in turn precipitates a decline in trust. And so that also tells us a very clear thing. There is opportunity for us to improve. There is opportunity for many of the people in the audience to work towards improving that situation of trust, to get people to a place where they can gain back the trust they had in public institutions. And so, this is something that's top of mind. It's very salient in recent elections. And so what can we do? We think of, from our assessment of the literature, two major takeaways. One, the important thing here is while people who experience a decline in health might not be taking part electorally, they are politically participating in other ways. They can join advocacy groups. These groups can be very powerful in mobilizing them towards issue positions that they care about. And the other thing, and I'm sure others in this panel will highlight, is the importance of trust. There has been an erosion of trust within society with regards to, in advanced developed countries, with regards to the democratic process and public institutions. Health and health system has also been a victim of this erosion of trust. But many of the people in this audience, health practitioners, policymakers, they're in a position to reverse that trend. We can improve health through prevention and cure and increase trust by giving people care that emphasizes their agency, that they are valued members of society. And doing so can improve their trust, which can have spillover effects for society more broadly. And the other thing that doctors can do is to ask their patients to engage in civic society. An important caveat to the figures from earlier, right? This map is the one exception to the trust story is people still actually trust their primary healthcare providers. So they are still an avenue to potentially communicate to patients, to tell them about, to correct this misperceptions of trust, this decline in trust in public institutions. And on the other hand, we want to, point out to policymakers that it isn't sufficient that you make public health policy changes. For the public to really to appreciate, to internalize these changes, these benefits need to be visible. Oftentimes they need to be universal, and it needs to convey a sense of agency to the people that you're administering to. And so it's important to not come across, the policies to not come across as condescending, that it be respectful of the agency of individuals. And one thing, and I'm really excited to have Flavia on this panel with us today, because one of the key things here is policymakers can work with health professionals and patient advocacy groups and civic society to really improve the engagement among people who've experienced this decline in health and have a gloomier outlook toward life, society, the economy, and politics in general. Thank you very much.
Thank you so much for this excellent presentation. And thank you so much, not for only showing us the analysis and the problem we have here at the moment, which is probably not intuitive, but also to point at some of the strategy that might help to establish trust. Investing in health and health system, that is one thing which throughout the series of the co-benefits webinars, the SDGs, we hear repeatedly that actually investment in health and health system pays out in other places. But not only the investment, you also make it very clear what can actually help. A little bit, of course, in health promotion and prevention, targeted into cure, but also investing into the engagement and into people and civil society. So thanks a lot. I think this gives us a lot of food for discussion, and I can figure that will be very interestingly picked up in a minute by Flavia and by Scott. But before that, Astrid, can we have the results of the poll?
Yes, I am just getting it up on my screen now. So for the first question, is health recognized as a key determinant for democratic participation in your country? 38% of the audience that replied said yes, and 41% said no. So that's rather tight, I would say. And 21% said don't know. Regarding the second question, have any health policies been introduced to support democracy through? Let me just get an overview. The majority said engaging with patient advocacy groups. So that's around 45% of the audience that mentioned this policy. And then there is also 42% of the audience that's saying that lowering barriers to political participation for people in ill health is also a policy that has been introduced. And then we have using health system strengthening as a political platform was mentioned by 38%. And then 14% said none of the above. So that's sort of my key summary of the poll results. Over to you,
Astrid,
Matthias.
thank you so much. When I look at the first yes-no question, and 38% of the respondents say yes, it's recognized as a determinant for democratic participation. I think we can still do better. When I look at the second question, then I think, that countries, at least some countries, are already kind of investing in participation and strengthening the engagement of citizens, in particular, through citizens' councils, civil society organizations. Very interesting. Thank you for this. And now it's my great pleasure to invite Flavia to take the floor. Flavia is from the European Patients Forum. And what we are discussing today, Flavia, is your day-to-day business. Of course, you are a Brussels-based organization, umbrella organization, but your members, they come from all the countries and they have lots of patient and citizens as direct members, and you also are very closely connected to patients. So please tell us your perspective.
Thank you very much, and hello everyone. It's lovely to be here. I think the results from the poll, especially the second question, are very encouraging for EPF, so for my organization, and for me personally, because it means we are pushing in the right direction. Maybe before I dive in, I'd like to say a few words about the organization I represent, the European Patients Forum. So we are an NGO umbrella organization representing patient organizations across Europe and across disease areas. We lead the collective patient advocacy in Europe, providing a cross-disease perspective from a wide European patient community to the policy-making process. I have to admit that when I received the invitation to be in today's webinar, my first thought was to do a quick research on the topic. So I headed over to Google Scholar, typed in health and democracy, and I saw that most studies explore how democracy influences health outcomes, but far less research, surprisingly, examined the other way around impact, like how the overall health of a population can influence democratic processes, which made me reflect on the question you raised today. What can policymakers do to increase trust in health systems? And how can health be further embedded in sustainable development? And I think the answer to this actually lies in understanding the cognitive and emotional components of building trust. Because trust in public authorities mirrors the trust we build in personal relationships. Think of somebody you deeply trust, a spouse, family member, friend. How did you get to trust them? And my guess is it took some time. It took consistent and congruent actions, dialogue, and not only talking about it, but also integrating feedback in a constructive way. And how do patient organizations fit into this scenario? I think I have two examples that come to my mind. I think the first one is a more hands-on type of example. So 2 years ago, EPF took part in a project called Periscope, which aimed to investigate, let's say, the broader social impact of the COVID-19 pandemic in Europe. And one of the studies that emerged from the project, and please, Astrid or Lucy, if you can share the link in the chat so everybody can have a look at the study. So this study showed that there's a correlation between mistrust in government and public authorities and vaccine hesitancy. So in countries where people didn't have a lot of trust in the government, they were less likely to get vaccinated. And this led the research team to the conclusion that one-size-fits-all approach is not really effective when it comes to vaccination campaigns. But the research also revealed that patient organizations are actually better equipped to fill in the trust gap because they represent, let's say, a more segmented population. For instance, let's think of a person with diabetes. This type of person is far more likely to trust information that comes from a diabetes organization than a public or general public announcement. So this person will find relevant and relatable information that addresses their specific concerns and needs in this dialogue with an organization or a community. Which leads me to my second example. This might be a bit more abstract because it refers more to shaping health policy. First, how do we find out what our community needs? And this is done through well-stated processes of consultation. So whenever there is a relevant policy initiative, for instance, now some really at the forefront discussions are about the revision of the pharmaceutical legislation, the health technology assessment regulation, the European health data space, just to name a few. So for each of these topics, we ran several consultations among our members, patient organizations, to obtain a consensus regarding what matters to the patient community and how we'd like to see what matters reflected in the legislation. These consultations represent the foundation of our policy position, our policy angles, which we later conveyed to the European institutions. And this is how we know what patients need and what they want. And then perhaps to take it a step further, I also have in mind the campaign. We ran this earlier this year in the lead up to the European Parliament elections. The campaign was centered around the Patient Organizations Manifesto, and this document basically advocated for a democratic and impactful involvement of patient organizations in policymaking. Because structured patient engagement, so from the earliest stages, can draw on the unique expertise and lived experience of patients and patient communities to ensure better alignment with real patient needs, improve patient information, adherence to treatments, also improve awareness and trust, and ultimately reduce costs to patients and to healthcare systems, which, you know, at the end of the day, leads to better democratic outcomes. And one of the manifesto's key points is just that: involve patient organizations in the development of policies which are complementary to the health sector and quality of life, social affairs, or social environment. And therefore, prioritizing this structured patient involvement in policymaking, as advocated in the manifesto, not only improves health outcomes, but also strengthens democratic processes, because it ensures that policies reflect the needs and the voices of the people impacted by them. And I think, in essence, this is democracy in action, right? Policies that are shaped to be responsive to the people they serve. Thank you.
Flavia, thank you so much for this perspective. And I think you made a very strong case with the three examples you just put on the table. One was how civil society organizations, patient organizations are actually stepping in and filling the trust gap. And the example was the vaccine hesitancy. The second example was the system design, actually. You know, we are not just kind of receiving we are not just at the receiving end for health policy, but we also want to contribute with our knowledge, our insights, our intelligence, and so on. And it reminds me very much of what Anil was actually suggesting. And the third one, I thought that was very interesting, you know, in the run-up to the European election, that you tell people, listen, that is at stake, you know, please cast your vote, make an informed decision. You know, if you have worries about the health system, it will not help to abstain or to go this way. So you're getting really involved as a civil society organization, as a patient organization, and this has, of course, a completely different impact than if policymakers or governments start telling you what to do. Fantastic. I think that's a lot of material, Scott, you can probably deal with, and I'm already curious to hear what you make out of all of this. Please, Scott, the floor is all yours.
Well, I think the most important thing is that the gold standard in an even slightly democratic country for getting a politician's attention is votes. If you're not getting votes as a politician, you don't get to do any of the other things you plan to do, whether it's simply be ambitious or whether it's try to change your country in a way that you aspire. So if the gold standard of getting a politician's attention is votes, then this is really important research. Employment, inflation, health, whatever. Those are all things that we do to try and get votes. But the votes themselves are what we care about if we're in politics, and this research has that. What stands out about it, I'd say, is two more things. One is the magnitude of the effects. If you read through this study, these effects are big. It's really hard to change people's propensity to do anything by 16 or 20%, and yet you see that. So if you want to change the way people engage in politics, it seems that their health status is a really big variable. And the other is the mechanism, which is trust. It's more actionable than I expected, because basically, as Anil said, bad interactions with healthcare and the rest of society, such as your employer, reduce trust and drive people in ill health toward the populist radical right or out of political engagement. So imagine it this way. You're going to a political leader, perhaps one of the many in Europe who were just elected and have only a few years to secure their future. Tell them, I can increase your votes and stop you losing votes to the populist radical right. You get their attention. But then you tell them the solution is a healthier population. You're starting to lose their attention again, because anybody who's dealt with public health researchers knows that the next bit is that a population-wide increase in self-reported health or life expectancy takes years, and it can be expensive, and maybe it's no fun, and a lot of things go wrong. So simply going to Olaf Scholz and telling him to improve health in East Germany if he wants to save himself in the next election isn't going to work. But then you tell them the mechanism, and that's very amenable to policy, because anybody who works in health can start to collaborate with patients and communities to find actionable ways to have more respectful, more supportive, more stigmatizing, less stigmatizing social and health policy. Policy that means that the recurrent interactions you have with the health system and maybe other social policy bureaucracies go well and respect you and your opinions and draw on your agency and don't make you wait in ugly offices forever to fill out repetitive forms. And that's amenable to policy work. That's amenable at every level to managers, policy experts, civil servants, NGOs, to think about ways that the health system does not breach faith with people when they most need it, and thereby drive them into distrust. That's something you can do to make policy that'll have an impact within years, and it's a good thing to do. And you can have a lot of photographs with happy patients in the hospitals as the election draws nearer. Might I add, by the way, that this dynamic that we've described, in which worse and less respectful health systems lead to loss of trust, lead to lack of political engagement, and voting for the populist radical right. Well, populist radical right parties in power tend to pursue policies that don't make better health systems, don't make them more respectful, make them more stigmatizing, less generous, and over time, often worse quality. So making worse health policy might be a business model for the populist radical right, but in the long run, it might even be bad for them. So the magnitude in this research surprised me. It went far beyond what we used to be able to see in older research. And it gives useful, if hard, advice on the mechanisms that we could use in order to avoid breaching faith with patients. In other words, the mechanisms are build trust, and you can do that with policy and management. Over to you, Matthias.
God, thank you so much. And to some extent, I have to say that I hear messages that could come from another context as well, because what you say is, health systems need to be very clear that they are responsive also to the non-medical expectations of the patient. They need to be respectful. It mustn't be condescending. They need to be accessible. And we've just seen, you know, problems in many countries, partially caused by the COVID-19 backlog, but also by the impact of austerity policies. We are talking about quality. People can trust the quality, and also, of course, there needs to be a lot of transparency, as I see. One thing which puzzles me, and maybe that is for Scott and Flavia later in the panel discussion, is we all agree how important civil society, patient organization is to establish trust, participation, and all this. But isn't it the case that in many countries in Europe, the space for civil society is actually shrinking, that there's more and more difficulty, you know, to act as civil society? But I leave this for a moment, and I would now like to ask all the speakers to switch on their cameras and their microphones. And Astrid, how's the chat box? Is there something in it?
It's very lively, Matthias.
Great.
Really good questions coming in. And I've sort of grouped them into two themes. One is expanding the scope, and the other one is methodological questions. So the first category in terms of scope, I was wondering if Nolan and Anil could comment on or provide more insights or idea about how we can engage the wider healthcare system professionals, such as nurses, and how training and education development resources could be developed. And the methodological questions, we have two that are revolving around corruption. So did you take this into consideration when you were writing the brief? How are you measuring health? It's a big one. And can you talk more about the studies behind the policy brief? So I'm going to start with those and then return my focus to the chat and see other incoming questions.
Well, this is already quite a lot on the plate, but Nolan and Anil, just answer the ones you feel best suited to answer, and Scott and me, we will try to address the other ones, yeah?
That sounds great. I think we can hit them all. You just might have to remind me about the different moving pieces here. So lovely to be here with you all. And also, what a stellar presentation by all our panelists. I'm absolutely stunned by how incredible they are and how well they've captured, I think, the key themes here. I'll first hit on the point about who's involved. So I'm not only a researcher, but I'm also a clinician in training. And so I think a lot about how the different pieces of the health system are involved here. And to maybe take a step back and give some context, for the vast majority of people, the face of the government they interact with the most is actually the health system. And that means that not only is it like your doctor is involved, but also your nurses are involved. The people that fill out or help you fill out the paperwork are involved. The social workers are involved. Once you leave the health system and you have to sign up for government services, if you do, the folks that help run the administration of the government are involved in this too. And so there's actually a wide number of people that patients, particularly those in ill health, end up interfacing with. And all of them, I think, have an important role here in building and maintaining trust. And so some of that is going to come in the form of making sure their interactions are affirming, that they feel welcome, they don't feel stigmatized by any one individual. But on a structural level, it also means making sure that the benefits available to them are actually visible, that people know that they have help when they need it, that those benefits are universal and not targeted to specific groups of people that make them feel stigmatized. And so I think there's actions that can happen both at the level of individual clinicians, but also at the structural level too. Next, I'll turn my attention to the kind of methodological questions here. And I'll also start by taking a step back to contextualize this brief. So Anil highlighted some of the excellent work that we've done analyzing data ourselves, but the brief itself is based on a massive review of the literature. There's something in the neighborhood of 175 citations of academic articles over the last 20 or 30 years packed into this brief. And those studies range the gamut from studies that compare across countries those that focus within countries, those that focus within specific communities, and those that even follow the same individuals over time as their health changes. And so I think one of the questions was about corruption, and I think it's a fair point that if you were to compare one country to another, the corruption environment, or many things indeed about the countries, might vary. But if you want to quibble with those studies, there's 100 others that focus within the same country, within the same community, or within the same individual, and tease out the relationships over time. I think a related question too is, how do we measure health, or how do we think about health here? And we also think about it both at the individual level. So we ask people, for example, how would you self-rate your health on a scale from very bad to very good? That's actually a surprisingly good way of measuring health that tracks onto a lot of things that we do care about, like mortality, physician ratings of health, diagnoses, and the like. Some of the studies use specific measures of health, like those that are specifically about chronic disease, or those that are specifically about mental health. And then some of the studies also take a broader look and look at community health measures. So the suicide or drug overdose rate in your community writ large, the life expectancy of an entire community, because there's a lot of different avenues whereby either your health or your neighbor's health might affect your politics. And across the board, we find that consistently they do affect people's politics.
Nolan, if I get right what you said, you say it's not just one study, it's not just one panel, but there's so much research around it, which is actually kind of supporting the thesis you put forward, even though with the data you have, it comes across very clear that Scott says the magnitude is very big. And number two, and this is also what I understand from your explanation, there's a lot of methodology behind it. And I see that you are almost eager, or at least prepared to respond to it, but it's a relatively strong methodology that's coming across from what you're saying. Anil, would you like to expand on this or add something?
I want to be mindful of time, and I can keep going.
No, take your time. Take your time. I think that's interesting.
Okay, so one of the things that we did, if we want to go technical for a quick second, is we wanted to assess various things here. So is this something having to do with the specific time period that was being studied? So in our work, we look at a 20-year time period that looks at the pre-financial crisis and post-financial crisis period. We were able to statistically account for factors that would have influenced the political climate of the entire continent. We account for factors that would have influenced the political climate of a specific country, the culture, the institutions of a specific country. So we tried to be very mindful to systematically think through, like we spent quite a long time looking at the public health literature, the social determinants of health literature, to identify the key determinants that they care about as explaining health, as explaining political behavior. And we wanted to make sure that we weren't, this wasn't confounded analysis. So one of the things that we do in our appendices is we show, okay, let's only look at demographic factors as accounting for this problem. Let's only look at political factors. Let's only look at socioeconomic factors. And then let's look at the combination of all of these individually and with each other. And what's surprising is throughout all of those different models, this relationship comes through. And there are expected reductions in magnitude when you account for somebody's income or somebody's education, but it's consistently there. And so to us, that's suggestive, yeah, this is an extremely complex endogenous process, but there is a through line here that is quite striking. So
excellent. I think that makes it very, very clear that the results you are presenting are pretty robust, actually, and that you have tested so many confounders that we can say this has to be taken super, super serious, and we should act on it. Flavia, can I ask you to come on board?
I was thinking about what you previously mentioned about the involvement of civil society and patient groups and patient organizations in policymaking. And indeed, this is something we've seen happening. So during the COVID-19 pandemic, health was at the top of the political agenda. Rightfully so. And yet in the past 2 years, I would say, it has decreased in the importance it was given. And And this, for us, means I think patients are the ones who understood quite quickly that there is also the reciprocal dynamic. So not only democracy influences health outcomes, but the other way around. So being in this position, patients, we do believe that it is vital for health to remain at the top of the agenda because, for instance, I don't know if we, as a society, have fully integrated the lessons learned from the COVID-19 pandemic. Are we prepared for another pandemic? No, we're not. So until we have that figured out, health needs to remain a priority. And how do you do this? I think at national level for national government or European level, for instance, in our case, first you need to make sure that the role of patients is institutionalized. And secondly, to provide sustainable funding for patient organizations so they can continue their mission, and also to fill in that gap of trust I was mentioning earlier, and to build capacity within their own communities for better patient involvement and representation.
Flavia, I think these are two very important leads, actually. If you want to have citizens engagement, if you want to have patients engagement, of course, some patient organizations might be powerful and strong enough, but many of them cannot finance themselves and they need to have support. And secondly, you need to have the platforms, where you really engage with policymakers and where it's not just the kind of token representation, but where you really make a difference in terms of providing intelligence, information, but also helping to shape health policies, and where you've been heard and where you can challenge a little bit, what's happening. And I think that in some of the countries in Europe, we are making interesting experience with citizen council, more on the determinants of health, but still very interesting stuff. Also here for the European level, very important lesson, institutionalization and continuous funding. Scott.
I'm looking forward partly to Nolan's answers to the next questions, but I want to underline that corruption is incredibly destructive of trust. So practically every experienced form of engagement with the health system of patients is made worse by corruption. The building isn't in good shape or it isn't finished because somebody took 10% off the top, or you're getting bypassed for care by somebody with a brown envelope, or the better doctors are fleeing to the private sector because the public sector is so dysfunctional. So corruption, in a sense, permeates these relationships, and interacting with a corrupt organization, it's no fun if you're on the outside, and it's not that nice if you're on the inside, because the mechanism of access to care is I know a guy. So the risky thing is that we know there's a lot of corruption in healthcare. The European Commission said it's the second most corrupt sector in the continent. If you're a high trust society and you have a lot of corruption, something's got to give. That's not stable. So stop ignoring the corruption in your country. And if you're in a country where people do understand it is corrupt, regaining trust is hard work, and you want to think about that.
Let's go. What to do about it? I look at my country and you have social legislation. So the sickness funds are obliged to go after corruption. Then they do. The Physicians Association are obliged to look into corruption. And there's an office, there's a prosecutor who's really specialized. And what do we do about it?
Prosecuting is a really good start. And also corruption tends to come from the top down. So to the extent that you're prosecuting high-level people, that sends an important message to lower-level people.
Yes, but there's also the corruption, like, for example, DRG upcoding, where you insert codes for more complex procedures, even though this is absolutely not necessary. And this is how you get your reimbursement.
the answer on specifically something like upcoding is stop running these really, really complicated systems that are so open to abuse, right? Where the price of your information technology influences your ability to manipulate the system. Doing things simply and in a way that people can observe without having a PhD in health policy is a good idea.
So it's system design. Astrid, I think we have time for another quick round of questions.
Yes, I've been deep in the chat looking at all the great insights from people that are still rolling in. So I just want to do a quick shout out to the audience. Thank you for your participation. I wanted, so some things that stood out was maybe around generalization. So does this happen everywhere? And have you come across in your research, Nolan and Anil, and maybe also Scott, across best practices, maybe also to end on a little uplifting note, from where can we learn the most? Maybe if you've come across anything in your studies. Thank you.
Thanks a lot, Astrid. Nolan, you want to take a start?
Yeah, I can start us off here. So to answer the question about generalizability, these relationships are surprisingly consistent everywhere people have looked. So I know a lot of the discussion today is focused on European countries, but it's present in Europe, but it's not just present in Europe. It's also present in the United States, in Canada, in Japan. To the extent that studies have looked at low and middle income countries, it's present there too. It's surprisingly consistent that if people have bad experiences with their health system, if they don't feel like their health needs are being met, they tend to distrust the institutions that they think were responsible for letting them down. And then the next step of disengaging from those public institutions in the democratic process is there too, almost everywhere people have looked. So yes, this is a worldwide phenomenon as far as we can tell.
No.
And then to comment on like the best practices here, we might separate some of the best practices by who we're talking to. So if we're talking to a clinical audience, the first step, of course, is making sure that care is affirming, that it's accessible, and that it enhances the agency of the people who are engaging in the care process. But I also want to say that there are some organizations, especially in the US, that are doing a wonderful job actually having clinicians help get people back involved in politics. So there's a really lovely organization called Vote ER that basically equips clinicians with a little QR code that then patients can scan and get information on how to vote. And if you really trust your doctor, it can be very affirming to hear that they want you to participate in politics too, and that your voice matters. That's clinicians. On the policymaker side, I think one of the challenges that policymakers have here is exactly the one that Scott highlighted, which is that as a policymaker, especially if you're a politically engaged elected official, you need people who are going to actually vote for you. And so one of the challenges here is making sure that people who otherwise have barriers to participating in politics, because maybe they have a chronic disease that doesn't allow them to get to the polls quite as easily, or they've been stigmatized by other interactions with the health system and they don't feel like the government wants to listen to them, policies that make it easier for people to vote, that encourage them to vote, can go a long way to making sure their voices are heard here. Also, directly soliciting the opinions of people in poor health, either by directly engaging them or by engaging patient advocacy groups or medical societies, like the one that Flavia represents, also can help bring those voices into policymaking and make sure that their needs are met. And so I think there's opportunities for everyone here, both at the individual clinical level, but also the systems level policymaking area that can make a very large difference in protecting the health of democratic institutions.
Thank you so much, Nolan. I think it's a very strong point you're making that this is an almost universal phenomenon. I'm curious to hear differentiations between countries which are already very close to universal health coverage and those which are on the way. But I guess there will be a lot of scientific debate based on your contribution. Anil, you want to add to this?
Just, one of the questions that we've had in the past, and Nolan and I have thought a lot about this. We've had conversations with Scott, with Matthias about this, is I think Jason Young in the audience had asked about correlation versus causality. And it's, that's part of we're very upfront about this in the memo, in our published work that these are interrelated processes. We try our best to be very systematic in trying to address known confounders. And in some of our ongoing work, we go from the correlational cross-sectional data to tracing individuals over time. And the idea is to get as close, I mean, the gold standard in a lot of work, I mean, especially in the health space, would be an RCT. But as Nolan and I regretfully write in our introduction sometimes, we cannot randomly assign the health of individuals and consequently cannot get a causal estimate. But we try to do the next best thing. And the thing is, you know, it's this, and Nolan emphasizes, and I should emphasize it even more, is that this isn't just one-off study. We shouldn't, you know, we should be Bayesian updaters. This isn't just one study that is making this claim. This is a corpus of texts that at both the community level and at the individual level is finding this relationship. And it's up to us. I mean, research needs to be done. And one of the thrusts of the memo that we wrote for the WHO is, and the observatory, is to say more granular data should be brought to bear to this question. We've found a relationship, let's stress test it. Let's make sure that policy is informed by the best evidence that is possible. We're trying to push in that direction with the data we do have access to. If you can send better data our way, we would love to as well.
Talking so much about trust, Anil, I have to say that the transparency and your explanations really make me trust your research and the robustness of the results. It's really very cool. Flavia, very quickly, you know, just 2 sentences. We are almost at the end.
I actually have a quite recent interaction in mind that made me, I remembered it while I was thinking about our conversations today. A few months ago, I met a journalist who was here in Brussels attending a conference, and due to a neurodegenerative disease, she had to use a wheelchair. And she was telling me that the hotel where she's staying is technically wheelchair accessible, but if you're staying alone in the room, you cannot really reach the shower handles because they're too high. And it made me challenge my view on the world, because I would never thought that that might be a problem. And I think democracy, or integrating health in democracy, is just about that, about acknowledging that there are different perspectives, that none of us holds the absolute truth, and the best way to move forward is just by cooperating and collaborating.
Flavia, this is almost a concluding sentence, but the concluding sentence is actually reserved to Nolan. Sorry, Scott, for jumping you, but Nolan and Anil, I mean. Anil, you are starting this session, and now you guys, please give us your last message for today, what you want the audience to take with them.
I think I'll just echo the main points here, which is that when people experience a decline in their health or a bad experience with the health system, they come to mistrust not only the health system, but also all of the public institutions that are tied up with the health system. And that includes democracy itself. And so there are opportunities here for not only individual clinicians, but also policymakers working at the highest levels to re-engage those folks, to improve their trust, and to protect democratic institutions.
Fantastic. Thank you so much to all the speakers. Thank you to the audience. And Lucy, before we close the session, can you upload the slide on the 10th for the event on the 10th of December? So we will have a big symposium here, which we're going to stream on the Tuesday, 10 December, 15:30 Central European Time, leverage evidence for health systems transformation, passing the baton at the observatory. It's a symposium at the occasion of the incoming new director of the observatory, Ewout van Ginningen. And we're all looking forward to this, and we hope that you will join us. You will receive links early on. Thank you so much to everyone, and hope to see you soon. Bye-bye.